الناس حبك بيض الله قلبك بيض الله قلبك كن سامحا لخصمك ألقى خصمك أحبك بيض الله قلبك بيض الله قلبك واحتفل بالمودة إنما
Assalamu alaikum wa rahmatullahi wa barakatuh. Ahlan wa sahlan wa marhaban bikum. Good evening and welcome once again to another edition of the Sulaimaan Ravat Show. We are coming to you live from our studios here in Sunning Hill, Johannesburg. It's a beautiful Friday evening. You'd never say that we're still in August, although spring day is just a day away. But it's been warm for quite some time and enjoy the good weather and let it put you in a good mood leading into a good weekend, inshallah, Almighty willing. Now, when we talk about the country, when we talk politics, one of the key focus areas is health, and for obvious reasons. Everyone kind of agrees on that, the importance of it, the priority that it needs to be given. And that is our focus this evening, and we are fortunate and honored to have in studio with us this evening MEC for Health in Gauteng, Dr. Bandile Masuku. Dr. Masuku, thank you so much for your time this evening. Good evening and welcome.
Good evening and peace be upon you with your viewers.
Well, just to bring our listeners into the picture in terms of your own life story, in terms of what brought you to this particular point where you MEC for health. Tell us a little bit more about yourself.
Born in Soweto, in Snawane specifically, born and bred, matriculated there, and then went to Pretoria, Medunsa, to do my medicine. But I started off with BSc, then went on to do the medicine degree. Upon finishing, I then started specializing. Took 4 or 5 years specializing in obstetrics and gynae. And then after that, joined Krisani Barakwanath as a consultant and a specialist, running a twin clinic, which was an antenatal clinic for multiple pregnancies. I've been a student activist all my life. I don't remember any time when I was not in a meeting. I was part of SOSCO, which is a Soweto Student Congress, then went on to be member of COSAS, leading COSAS in Soweto. Then at medical school, I was a SASCO member, I was a president of the SRC, also became the president of SASCO, national president of SASCO, when I was doing my 4th year until I completed, which was almost 2 years. Then went again, became a ANC Youth League leader in Gauteng. I was the treasurer, provincial treasurer. All along, also working in the policy space, particularly on education and health. Worked under Dr. Zweli Mkhize when he was the convener of the subcommittee nationally. So I've got a fair background of being an activist and also being exposed to policies, development and policy making around health and education. And maybe just to also add that I was also a member of the task team, the ANC task team on NHI, which made the first proposal on NHI.
Interesting and a rich background, I must say. When we talk about health, right, it's relative to to different people. Some look at health from the prism of their local clinic. Others look at it from the prism of public hospitals. People look at it in relevance to how they interact with health facilities, etc. But if you can give us a holistic overview of the Department of Health, you the MEC, what is the department made up of? What does it entail?
I think you are spot on when you say that the whole issue about health is all about experience. You know, how the patients and how the relative who accompany the patients experience our facilities or the system, how easy it is to access our facilities, was there any problems, and our health system consists of hospitals. And in Gauteng, we are lucky to have 4 central hospitals and who are attached to 3 medical schools. And I think we're the only province that has got a high concentration of medical schools. And then we've got provincial hospitals, which I think there are 3. And we then have regional hospitals and district hospitals, and then a myriad of actually clinics around. We have a different type of clinics, which are 24-hour service, called the community health centers. And those are clinics that are supposed to be the first stop for any emergencies that we see in our hospitals. So basically, that's how our system is actually designed. So our patients are supposed to enter the system through clinics, and if the complication or the illness is more complicated or complex, then they will refer to the next level of care.
And within your department, what is the structure like? Do you have people focusing specifically on policies, others specifically focusing on sustainability of existing projects, others looking at what are the trends and trying to be ahead of the curve? If you can give our viewers some insight into the functioning of the Office of the MEC for Health.
Okay, the Office of the MEC is actually separate from the department, you can say that. But the department consists of different units. The one that looks after the human resource and corporate affairs, the one that employs us and pays us, and then there's communications that is responsible for our communication strategy and what we put across as the department. And then we've got legal aid services, which deals with the issues that relates to medical litigation and also general legal issues that are pertaining our contracts and all that. And we have a monitoring and evaluation team, which is also related to policy making, which is the one that deals with real issues of policy making. And then we've got the hardcore, the clinical and hospital services. Those are the ones that take care of our hospitals and take care of our clinics and district hospitals. So basically, that's all in all what the department looks like. We have different programs that we run, which are related to the main pandemics that we have, HIV and AIDS, non-communicable diseases, and those are the areas that we look at, the mother to child and school health, and that's what we do. So basically it's an overall holistic actually department.
Now, we've just had elections in May. There's a new leadership provincially. This is the time that you normally hear people talking about a 5-year plan. In terms of your portfolio, health, what broadly speaking, what's your 5-year plan? What are the pivots of that plan?
I think we've decided that we're going to concentrate on visible and impactful objectives and priorities. Yes, there are those that are in the background, when we talk about targets of immunization, people who are on ARVs and all that, but we wanted to concentrate and prioritize on impactful things. Like we said when we started, that health is about experience, so one of our priorities, just changing how the patients and the relative who come to our hospital experience healthcare. And that contains a lot of factors, waiting times, easy access. And when we talk about waiting times, it's whether waiting to open a file or to be seen by a doctor or to be operated on. And that's what we need to improve, because there's been a great challenge in that space. And it's also related to shortage of staff. And that is then leads us to the second priority, which only relates to our staff members. We have inherited a lot of staff members who are pretty much depressed and their morale is very low. So we are concentrating in making sure that we motivate them and we deal with their mental and spiritual well-being. And we have a lot of programs that are going to lead us into that space. These priorities are interrelated, because if you deal with the other one, it will actually affect on the other. If the staff morale is high, motivated staff, happy staff, it will also improve on the patient experience on the other side.
How difficult or how colossal is the challenge when it comes to resources and infrastructure that is available? Prior to the elections, I had the former MEC for Transport, Ismail Vadi, on the program, and he was talking about how Gauteng, being a smaller province, has got this challenge of so many people from other provinces gravitating towards Gauteng, and that was putting a burden on the transport infrastructure. In terms of health, how much of a factor is that in terms of resources that are available and infrastructure? There's only that many clinics and that many hospitals, and you have this province towards which everyone is gravitating.
Yeah, our infrastructure in all, whether it's roads, schools or clinics, it's overstretched and has become inadequate over time, and it has not translated to an increase in budget. So we have 15.8 million people in Gauteng, and we normally look after 25 million people throughout all our facilities, people who walk through our gates per annum, and that's a huge number. And obviously it puts a definite pressure on the system. So our resources are not adequate. The budget has not increased in the last 10 years or 15 years. The economy is not doing well, that we know. But as Gauteng, we are suffering, the brunt of taking care of a whole lot of the country, because we see patients from KZN, we see patients from Mpumalanga, we see patients from Limpopo. So we are basically carrying the whole load of the country here.
All right, we take a break. When we come back, we continue the conversation with MEC for Health, Dr. Bandile Masuku. Welcome back to the program. We have the MEC for Health, Dr. Bandile Masuku, in studio with us this evening. Prior to the break, we were talking about the overview of the department, the functioning of the MEC's office, and also the 5-year plan and the current burden on infrastructure and the strain on resources when you've got so many people within the borders of the country gravitating towards Gauteng, and then you also have those beyond the borders who, when they come to South Africa, they seem to have a preference for Gauteng. Now, Doc, the story that has been in the media in the last few weeks has been about the National Health Insurance Plan and the announcement by the National Minister, NHI. You mentioned earlier on when you were telling us about your own life story that you were part of the project committee looking into the NHI. Tell us, when was it conceived and how was it conceived? What led to this particular process?
In fact, it started on around 97, 98. There was a committee which was known as a Bloomberg Shisana Commission, which was meant to deal with universal health coverage. And Bloomberg, that he ended up going to Discovery and also implementing most of the principles around Discovery about universal health coverage. Mm-hmm. But then after the 2007 conference of the ANC, it also reignited the discussion within the ANC, surely looking at how the constraints on resources is around the public health. So the discussion has been there for long, and it's only now that we start to seemingly get around it. The policy document that we submitted was discussed in the NGC in 2010 in Durban, and we were clear that we wanted to implement it quite on, and then after that there were pilots that were put up across the provinces just to see the models and different things that could be handled. So it has been over a period of time, and I think the time of implementing is now.
Now, when something like this becomes a bit controversial, then politicians make statements, the media report on various angles, various opinions, and in the process, the waters can become somewhat muddied. People get a bit confused. The average layman on the street will have heard about it, but they may not understand what it's actually all about. In simple layman's terms, what is the National Health Insurance, and what is it trying to achieve?
What is supposed to achieve? It's a funding model. It's a funding model of the national health system. You'll remember that over the period of 25 years, we have been in the process of, in actual fact, developing and building one national health system. And I think, yes, we have been very successful to a greater extent to create one system. And the funding now that we have with NHI is going to help us to create a one health system in the country, which almost will also integrate the private health care and make sure that private health care is also part of the system that we manage as as government. But I think if you want a one-sentence type of explanation, is that we want to eliminate out-of-pocket payment on the healthcare system at any given point.
Why do we need to integrate the private healthcare system? Because this seems to be one of the points of contention. Many says this NHI will be the death knell for private medical aid.
I don't see it as a death nail on the private. There will be some advantages that will come to the private sector, about it. But the issue is that we want to create a pool, a funding pool that will accommodate and increase our fiscus. We now currently government spends money on taxes, on medical aids, and medical aids to individuals and also to companies. RAF, Road Accident Fund, also has some bit of funds there which will be incorporated to the National Health Insurance Fund. Compensation, employee compensation will also go to the same fund. So the National Health Insurance is going to create the pooling effect, create the solidarity, social solidarity that even the medical aids talk about, because those who are sick will actually subsidize those who are ill, those who are young and healthy and fit will subsidize those who are old. And in this case of the National Health Insurance, those who are poor will be subsidized by those who are rich. So it also creates that element of social solidarity, which is a primary, one of the primary principles of the National Health Insurance.
At times when you have discussions like this, arguments are somewhat simplistic, but they need to be addressed nonetheless. When you look at social media, some people are saying, but we're already paying tax. There's already a fiscus, there's already a pool. Surely healthcare can be funded from that pool. Why the need for this new funding model?
Remember now that the medical aids only cover almost like 12% of the population. And those are the population that normally get, or people say, full access to private care, but I have a different view on it. But that is the money that also government is spending on that small number of the population, whilst the whole lot of the population shares the whole other fiscus. And we think that it's a bit unfair, for us to be spending so much money on a few individuals. And we want to create one single pool and able to have everyone have access to health care.
But just to be clear, that 12% that benefit from private medical aid, is the state really carrying that burden, or is that burden coming out of their own pockets?
Remember that there will be tax rebates. All people who are on medical aids, they get tax rebate from the state. And that's the money that ordinarily could have been diverted to this fund, and which will be diverted to the National Health Insurance Fund. Also, companies who give people medical aid, they also get tax rebate, and which is a state contribution. So the state contributes, and it contributes a whole lot of money to these individuals, and who are very few, and hence the public health sector needs this amount of money, which can able to help us to get more infrastructure, get more doctors on board employed, and so on and so on.
So in practice, will there no longer be any private hospitals? Will it be a case of everyone is now entitled to free healthcare, but you all use the same facilities?
We are a democratic country. I think there will be space for those who will want to still use private hospitals or private GPs on their own cost. It should be on their own cost, not on the cost of the state. But everybody else, including them, they will still be covered and will still have free access to all the facilities across the spectrum.
But isn't that the status quo in a way? For example, if I have medical aid, right? But if I walk into a state hospital, I still have access as a citizen of the country. The only one difference based on what you're saying is currently, if I have medical aid, I would be getting a tax rebate, and the service provider will be getting a tax rebate. So what are we saying? That we're just doing away with the tax rebate, and private medical healthcare will become more expensive, so more of that money can be allocated to the public healthcare service, making it then possibly unaffordable for most of the middle class to afford private healthcare. They would then gravitate more towards the public healthcare system, and private healthcare would be for the super rich and the elite.
It should be like that, because those who afford, actually should be, but the burden should not be also on the state and the state subsidizing them. And we think that the majority of our people will actually benefit, and those who are actually disadvantaged. But in any point, what we have said now is that even the middle class, now it's August, it's post-winter period. Most of the medical aids have run out. They've run out of their cash benefits in the medical aids. And where do they end up on? They end up in our same space. So we also fund, I think we should say that the medical aids make a lot of profit. The executives in the medical aids, they get a lot of salaries. They spend a whole lot of money on marketing, and which doesn't really go to the basic thing that is health provision, actual health provision. So we are arguing that the National Health Insurance won't be doing that. There won't be executives who will be getting bonuses. There are some medical aids where a CEO got a bonus of 135 million, which is ridiculous, and it means that money comes either from the state and from the pockets of the very same people that we are wanting to make them to avoid paying out of their pocket, for their medical care.
I want to raise some of these points because it's such an important discussion about the national health insurance. I mean, you see some of the opposition parties claiming that this whole concept is unconstitutional. What's your response to that?
Unfortunately, our constitution is clear. You know, it has got human rights, a bill of human rights, and which actually puts it clearly that everybody has got a right to health, and it shouldn't be about your ability on how to afford or not to be able to afford. And I think the NHI actually puts it very clear that it's going to respect, you know, human rights. Those who want to pay from their pocket, they will have it, but we have to cater for the majority. And I think as government and as the ANC government, that's what we actually want to.
What's your response to the argument that I've heard in recent days that, okay, conceptually and in terms of the idea, you have to agree with it. It's about social solidarity. It's about a greater, not only greater access, but a greater quality of healthcare for more people. However, if you look at the track record of the state road accident fund, it's not being managed all that well. We just come out of the state capture era, so to speak. There's this fear that there's going to be a greater burden on taxpayers who make up a small percentage of the population to fund this particular model, and that it's going to be mismanaged, and this objective of greater access to healthcare and better quality healthcare will not really be realized. Actually, things could become worse because of the marginalization of private healthcare.
Not really. I think the most important thing is that the fund will be a different public entity, like which is not the same as COM and the others, and how it gets managed and in terms of its mandate. So those 3A entities are entities that normally don't have the ability of even acquiring or even investing or even using money. So the money that comes in will be going directly to the service, and it will just be managed to take it to where it's supposed to be. And that's how simple it will be. Of course, pessimism is something that we know. I think it's a function of philosophy. I think most philosophers are actually pessimistic. But I think in the act of doing things, we'll have to correct our errors if there are mistakes, and we move on. But I think we have to look forward to a positive outlook. Corruption is bad. Society must deal with corruption in all its entirety, and it doesn't mean that we can't get into projects that will benefit the majority because of the fear of corruption. We'll deal with corruption as the state capture is part of the process of exposing actual corruption. Fairness and transparency makes it easier for everyone to understand what is happening. And I think the fund itself will fund itself in that space.
Some of the naysayers have been saying that it's a good idea, it's good on paper, it's not going to happen because there isn't money for it, and the kind of figures that they've been putting, they're saying this NHI is likely to cost more than that nuclear program that was mooted during the Zuma era.
Those are pessimistic, and they are creating scarecrows. The fact of the matter is that the budget that is there in the health system now, which is over 200 billion, will be the base of what the fund will be. Because it's not like there will be a new fund or new money over and above that is there. So the fiscus that we have will still be there, and will still going to form the base and the core of the funding. And then the additional funds that will come in from your road accident fund, from your compensation and other taxes that we still pay, whether you smoke or you drink or you do all this, those are the funds that will actually play and increase the fiscus. So basically we are going to utilize and structure the fund in a way that it will be able to cater for everyone. But definitely it's going to be an increased fiscus. And if there is a need after we have fully established that we need more money and how we get it, it's something that the public and the South Africans will have to determine. The lucky thing about South Africa, is that we are a democracy, a participatory, democracy. So whatever we put in as a proposal goes through engaged debate and engagement. So it doesn't become just a one totalitarian type of an approach. So we are going to come up with a perfect model of NHI, because we are not going to transpose it from any other country. We are going to have a South African NHI funding model which is going to be specific and suiting our actual conditions, like our constitution.
Lastly, on the issue of the NHI, what kind of time frames are we looking at? I mean, it's open for debate, and it's before Parliament, and how long is all of this likely to take before it's actually implemented?
We are hoping that by 2026 it will be fully implemented and fully functional, and it will be in full operation. And in the process that we are doing that, because other people have argued, and I also one of those that will argue that in Gauteng, in a real sense, access is not an issue, but quality of care is an issue. So tied to the discussion or tied to the implementation of NHI is an improvement of the quality of service, and that's what we are all about. So NHI, its objective ultimately, besides giving access and eliminating out-of-pocket payments, it is also going to be part of improving the quality of care in the country.
All right, it's time now for another break. When we come back, we continue the discussion with the MEC for Health. Welcome back. So this evening we are chatting to Dr. Bandile Masuku. He's the MEC for Health here in Gauteng. We had a good discussion about the NHI prior to the break. And in the very first segment, we were talking about the 5-year plan for the department and the overview of their activities. We focus now a little bit more on the state of hospitals in the province. What's your own analysis of the current state of hospitals in Gauteng?
I think it's not also a new analysis. I think everybody knows that our facilities are old and they're inadequate, and also they've not been renovated or refurbished after a very long time. And now we know that in 2017, an OHS report came that the facilities themselves are not safe. And we have made a commitment as the current administration that our concentration would be on making sure that all our hospitals are compliant. But we don't want to do piecemeal. We want to do everything at once, refurbish, renovate, do security upgrades, and make sure that the look and feel of hospitals is actually a look and feel of a health facility where you're going to get healed and get cured. So we are committed. There's budget, over 2 billion budget that we have put aside just to do exactly that. So in the process now of making sure that process starts early in October or mid-October, where it will be done by the end of this financial year.
When you look at the analysis, what are the root cause issues in terms of the state hospitals not being what they ought to be? The one is what we spoke about earlier on, lack of resources and infrastructure and that kind of thing. But when it comes to competency, when it comes to management, as far as state hospitals are concerned, what is the department's analysis in that regard? There's
been a different opinion. I think beginning of the first period of the 25 years of our democracy, we found that there was a lot of administrators who came in running hospitals, running clinics, who were not very much competent and who didn't even have insight, And I think the previous Minister of Health made a point that you find a principal running, a hospital. But when he came in, he made sure that we create a cohort of leaders within the system who understand the system itself, who've got the background, your nurses, your doctors and everything. But I must also say that it doesn't make you a better manager when you are a doctor, but also we had capacity programs where the CEOs and everybody else went into training. So the training of our managers, it's an ongoing program. Now we had 50 or so odd managers who were graduating on Tuesday of a program that is aimed at improving how the system can be run, as a high reliability organization. That's what it's called, a high pressure reliability organization. And those young leaders who are waiting now to be actually deployed where they're supposed to be, and it will be on merit and also on the energy that they possess.
You can disagree with perceptions, but perceptions are people's realities. One gets the impression sometimes there's a lot of negative perception about the quality of service, if we can put it that way, when it comes to state hospitals. Regularly, you'll hear in the media that, someone went, they were critically ill, basic, medicine was not available, or equipment to do the basic tests and that kind of thing. As a department, what's your PR strategy or your comm strategy, if you like, in terms of dealing with these perceptions?
I think the important thing is which we are dealing with is the issue of generalizing, because people tend to generalize. You know, they use their own experience and make it as if it's a general occurrence in our hospitals. So what we've been doing in the past 3 months is to make sure that we deal with all the complaints that have been actually emanating from our hospitals, and we've been dealing with them a whole range, whether it was through social media, your Twitter, your Facebook, but we've been able to get them to understand the other situations and resolve them. But one thing that is important that we are not doing very well is also to tell the actual story about the Gauteng health system, because there's a lot of good healthcare workers who have been carrying the burden, carrying the system going forward. People say the system is collapsed, but that's not true, because people still go to the facilities, they still get treated, and one odd incident does happen and it doesn't make it that the whole system is bad. You know, we even had a groundbreaking operation that was done in Steve Biko recently on the implantation of ear bones, which were artificially created at Steve Biko. So those are things that people don't know. You know, they don't know that in George Mokare, you know, which they say and write badly about it on Facebook, that we've got one of the greatest laparoscopic surgeons there. You know, the head of department of our department now, Professor Lukele, he's a well-renowned spine surgeon. You know, and these are people that reside and do their work in the public healthcare sector. And normally they make comparison with the private care. And normally I also opt not to talk about the private care and also only talk about our own institutions and our strength and our organization that makes it easier for anyone to get help. Yes, we do have adverse events, we do have those isolated problems, but it doesn't make the whole system bad.
One of the biggest tragedies in recent times in Gauteng has been Life Esidimeni. It became a big political burden. I mean, not only for the former MEC of Health, but for the ANC leadership as a whole in the province, for the Premier. What lessons have been learned from that you carry forward into these next 5 years?
I think one important thing is our partnership with the civil society. You know, because they also act as a good measure of the quality of service, and also they act as our first responders to a crisis. And I think what happened in Life Esidimeni was a matter that when the civil society came out and report, we tend not to respond. We actually ignored it. So one of the things that we have said as the department that will be responsive and will engage, you know, and we are not going to be sitting in the department, in the offices. We'll be engaging in all the facilities, and that's what we do every day of our time. And if you look at my timeline on Twitter, I respond to questions, I refer complaints as they come, and most of them, I think close to 80% of them have been responded appropriately, and that's what we're doing. So Life Esidimeni gave us that understanding that we need to be responsive and we need to be engaging, you know, and not be aloof and not listen to anyone. The second lesson about Life Esidimeni is that clinicians, doctors, nurses must make decisions on patients. You know, politicians can't make decisions on patients. You know, hence our mantra that we're trying to that we have adopted is that we want our system to be patient-centered, to be clinician-led, and also to be driven by stakeholders, you know. Also tied to the whole thing that the community must also take responsibility and also live up to the obligation of taking care of their health.
Right. We take our final break. When we come back, we'll be wrapping up the discussion with the MEC for Health. Welcome back. So this evening on the program, we have the MEC for Health, Dr. Bandile Masuku. We've been having a very interesting discussion about a variety of things. Early on, we spoke about the 5-year plan for the department. We spoke extensively about NHI. We've also been speaking about the crisis, the challenges rather that the department that is faced when it comes to hospitals in Gauteng. Is there still an ongoing problem, Doc, with vacancies that need to be filled provincially in the healthcare system?
Yes, there are vacancies, and now we have budgeted for them. In mid-September, we'll be advertising a whole range of them. I think there are almost around 1.5 that are there, which are funded and vacant. And we are still going to create more of the posts that are actually needed. We have one of the things that we have concentrated on and prioritized is to make sure that we are able to increase our workforce and make sure that it actually becomes sufficient and it's used efficiently. Because sometimes numbers don't really give you the efficiency. We also have to put systems in place to make sure that the numbers do give us the quality that we need.
You know, prior to this live program, I was interviewing earlier this evening the acting CEO of Transnet for a program in a few weeks' time when we won't be live because of my travels. And we were speaking about the fourth industrial revolution. And he was saying, well, we already need to start speaking about the fifth industrial revolution because we are in the midst of the fourth. In terms of health, how has this fourth industrial revolution, as it's dubbed, impacted on health positively and negatively? And within the health space, are you already starting to look and project and plan for the coming of the fifth industrial revolution? Because there are those who say the space between these revolutions are going to be much narrower now.
They're going to be very marginal. We're talking about artificial intelligence on the fifth one. I think we have not really taken advantage of the possibilities that the fourth industrial revolution has given us. But it's one of the things that we're looking at, like in terms of digitalizing the files, you know, so that we also reduce the time of a patient waiting to open a file. It can be done easily and be actually digital. You know, there are some parts that we have done very well. There's something called a PEC system, which all our X-rays are saved on a cloud and they can be viewed on any point instead of printing them. And if you have done one in one of our facilities in Gauteng, it can be viewed anywhere else in the facilities. So there are glimpses of that, but we have not fully taken advantage of it. And we are hoping that when we get into the next coming financial year, we'll be able to even unleash and roll out a number of actually projects. Digitalization is one, making sure that our hospitals are paperless, creating a system where people can be monitored and reviewed at home without anyone going there. So there are a number of actually, possibilities, and we have received a lot of proposals, and which most of them make sense, and we are going to try them out because we have to give every opportunity and see which one will work us to our benefit. But we are definitely embracing the technology that is coming out, and we are happy that it will increase our efficiencies.
In terms of artificial intelligence in specific, what are your thoughts? How will it open up opportunities in the healthcare space?
It actually just increases precision on diagnosis. You know, it excites me because one of the projects which I'm going to go back to, it was on just prediction on when you can deliver the twin pregnancies which are in danger, you know. And the most important thing about the artificial intelligence is that we need to create a better and proper data capturing, you know. And that's what we're doing. And I think that's what it will do. It will just make sure that your diagnosis is more precise and you're going to be able to deal with it. The other aspect that we're still far from it is the one that involves treating a patient according to the genomics that they have, their genetic makeup, you know. And we know that there are people that maybe don't respond to particular antibiotics because of their genetical actual makeup. So the artificial intelligence is going to give us a whole lot, you know, in procedures or surgery. You know, there's robotics, you know, and you know the advantage of robotics is that it goes into spaces or curves around organs that your ordinary hand and your ordinary visual eyesight won't be able to see and won't be able to operate better. So artificial intelligence has got a good room to make sure that when we treat in the next coming 10, 20 years, we are going to just increase our precision and making sure that we treat patients more efficiently.
As we wind down the program, I want to talk a little bit about doctors. We hear in the media about exodus of doctors. We hear claims that non-black, so to speak, Indians, coloreds, whites, feel they are being marginalized in terms of getting access opportunities in university to study medicine, then they're going overseas, they come back, there's complications in getting their certification recognized. Again, with regards NHI, one of the claims has been that it'll lead to an exodus of doctors. When it comes to doctors, what is the state currently, in the province in specific and nationally as well? Are there fewer youngsters taking up medicine? Are more of our doctors, is there brain drain, looking for greener pastures overseas?
You know, the discussion of brain drain, I've experienced it in different forms. Even when I was in medical school as a student, we had a debate about people who were opposed to community service. You would know that after completing our internship, we then do community service. And there were people that were vehemently opposed to community service. And one of the threats and the scarecrow that was put across at that time was that, no, when we finish, we're going to go. You know, so brain drain is a general problem for all the health systems in the world, even our neighboring countries. I think Zimbabwe, they look at us as if we are people that are taking all their doctors, you know, and even in the UK, it's the same. So the issue is just how we're going to utilize what we have and, you know, maximize the doctors that we are training. And there are a lot of studies that have been done, you know, even in terms of urban and rural, you know. There's the debate that, you know, but there's a brain drain in the rural area. That's why Gauteng is more populated with doctors and everybody, because people don't want to work in the periphery. So the discussion is not new, and it's not an issue that it's going to worry us to a point where we actually panic. But we want to make sure that we keep our doctors that we train. We increase the capacity of our medical schools to train more. We are having a discussion with UJ, for example, now in Gauteng, that we create another, you know, medical school in their university to just increase the space of doctors. And doctors, youngsters are actually interested in medicine, because a calling, you know, it's not only for the few, you know, taking care of patients a lot. So all our medical schools are indicted with applications. Our Cuban program, the Mandela Fidel Castro program, it actually also has helped us a lot, just to give us some surge of, you know, of the doctors that are trained there. This year and next year, I think we're going to receive 1,000 more coming back from Cuba, which is a good boost from us. And like you said, there are those who are coming from India, China, and Turkey who are coming back. The only challenge that we need to do is to make sure that when they come back with the HPCSA, we're able to make their registration seamless and be able to make them to be integrated back easily.
Doc, we have about a minute left. Your concluding thoughts, message to the nation?
I think there's an emerging optimism. I feel it and I sense it, and most people, I think those who have been following us, they get that sense that there is optimism that is coming, and NHI is also giving us that positive actual feeling. So they must just watch the space and support us, and make sure that we're able to change these fortunes of the health system in Gauteng. We won't do it alone. We need everyone and all the partners that we can get.
Dr. Bandile Masuku, thank you so much for your time and all the best.
Thank you, and thanks for having us.
That was the MEC for Health in Gauteng, Dr. Bandile Masuku, joining us this evening on the program. To all the viewers, until next week, inshallah, Almighty willing, have a great weekend. Assalamu alaikum wa rahmatullahi wa barakatuh.
وامنح الناس حبك بيض الله قلبك بيض الله قلبك جميل المساعي وامنح الناس حبك بيض الله قلبك بيض الله قلبك كن سموحا لخصمك ألقى خصمك أحب